Welcome to Population Health Information Technology, using technology to translate population insights into excellent patient care. This session will take about 30 minutes to view and is the third of 4 sessions in this series. This session will focus on the technologies that support population health and value-based care models and how that data translates into excellent patient-level care. Our objectives in this third session are to discuss care coordination through the lens of health IT, identify technologies that support population health and value-based care models, and to explain how population health data within these technologies is translated into actionable knowledge to drive care. It's very likely that you are already using some of the technologies we cover in this session, and some may be new or unfamiliar to you. As we discuss the individual technologies, keep in mind how we use these in the context of value-based care and how we prioritize them for specific workflows within this new care and payment model. We'll cover more about how the technologies work within workflows in Session 4. Here's a list of the many acronyms and terms we are using in this series. Please pause on this slide if you need to review any of these. Many of them were reviewed and defined in Session 1 of the series, and we will cover and define the new acronyms during this session. In Session 1, we reviewed the broader context of how technology is used to support population health management in value-based care payment models, and in Session 2, we learned more specifically about the components of population health management, vendor examples, applications, and the major steps of data collection, analysis, stratification, and utilization. We covered how risk stratification is done, what the typical categories of risk are within a population, and also briefly talked about how population health management can aid in improving health equity, leading to a reduction of disparities in your patient population. In Session 2, we focused on healthcare IT tools that help support management of populations or groups of attributed patients, with a particular focus on data analytics and stratification. In this session, we're shifting to focus on IT tools that can be used to support care management and engaging patients. The healthcare IT tools we'll talk about in this session are used to manage the patients and patient needs identified using the tools we discussed in Session 2. We'll walk through these in more detail in the coming slides, but these are examples of the variety of care management technology tools that can be used to support population health management. They fall under 3 categories: patient engagement tools, such as patient portals, which have an increasing number of capabilities that may include provider-to-patient communication, lab results, scheduling and reminders, and the category of clinical and care management tools such as admissions, discharge, and transfer or ADT alerts, clinical decision support, CDS, to provide patient-specific information, or telehealth. The third category, data exchange, includes the data mobilization tools, primarily health information exchange and community information exchange. Now we'll take a closer look at health information technology at the point of care. As we learned in Sessions 1 and 2, value-based care relies on being proactive and getting ahead of health issues before they become emergent or acute. Effective care planning is central to keeping patients healthy and supporting them in moving toward their health goals. Team-based care plans with patient goals and involvement are the proactive emphasis of value-based care. Nurses often lead care teams, but there are often other team members that take a lead in this role. A robust care plan includes an emphasis on helping patients achieve their health goals and includes addressing social determinants of health. Keep in mind that approximately 80% of a person's health is influenced and impacted by the environment where they live, work, and play, and this is why learning about a patient's social determinants or social needs is important to constructing a care plan that is realistic and achievable given their environmental circumstances and ability to afford and follow through with treatments or recommendations. We will talk about how the care plan is shared among a patient's broader care team when we address health information exchange. Alerts provide real-time or close to real-time reminders and notification to guide chronic care management. Admissions, discharge, and transfer messages, ADT for short, are a way for a facility to quickly notify subscribers of ADT lists, often a care coordinator or case manager, as to the presence or status of a patient. There are many other events that can be communicated beyond admissions, discharges, and transfers, which all come under the ADT umbrella. Clinical decision support is another component of being proactive and helps providers with some portion of the burden of making sure best clinical practices are observed in encounters, not missing immunizations that may be due, screenings, etc. Many EHRs incorporate clinical decision support in a variety of ways to support providers' ability to deliver safe and quality care. Under value-based care, the question for your facility may be, how can we do better at utilizing CDS capabilities? We'll continue to explore direct patient care technologies that support value-based care. While we do this throughout the session, continue to think about and apply the lens of people, process, and technology, and how we have to reshape these components of workflows to be as proactive as possible. The goal is to achieve the best possible health for our patients and simultaneously seek to control costs or reduce costs to unlock the financial incentives of value-based payment contracts. While telehealth is not practical for all healthcare needs, telehealth allows us to think about providing out-of-the-box care outside of our traditional brick-and-mortar settings. The bullet points listed on this slide are just some examples of uses for telehealth and not limited to these. One of the most successful uses of telehealth that emerged during the pandemic, which precipitated an amazingly rapid adoption of this technology, was behavioral health due to the ability to connect from internet-enabled locations along with reducing the perceived stigma of accessing behavioral health services in person, a way to increase privacy for recipients of these services. Telehealth has also had the added benefit of a reduction in missed appointments for all types of clinics. Rural health has had its unique challenges in telehealth implementation, such as limited broadband and technology access. Use of telehealth to support access to specialty care has long been a rural priority. Rapid growth of telehealth utilization during the pandemic and regulatory flexibilities have expanded support for telehealth services directly to patients' homes. This has opened up new opportunities to consider how telehealth can be utilized to support value-based care delivery strategies that result in higher quality and lower costs. Here are some additional uses of telehealth that you may wish to consider and explore. Each type of intervention or treatment has, of course, requirements and/or restrictions with regards to billing for such encounters. For example, the use of telehealth for dental care would be for evaluation of a dental issue. The use of telehealth for rural settings has allowed the use of specialists to provide or support care, such as telestroke, where stroke experts work with the patient's local doctors to recommend diagnosis and treatment that can be provided in their own community. One of the main considerations with telehealth that is applicable to other technologies is how you have deployed it for your environment and whether that technology is being used to the fullest. As an analogy, when we use applications like Microsoft Word, Excel, or our smartphones, we are often aware of and only using 5 to 10% of the capabilities available to us. It's often a matter of time and training to understand the full range of functionalities or capabilities, and, for telehealth, understanding what the possibilities are for reimbursement of using those capabilities for different types of encounters. There has been rapid growth in recent years in the use of remote patient monitoring as a strategy to provide more consistent, timely monitoring and support for patients that can lead to earlier identification and detection, interventions, and treatment of disease to prevent complications and unnecessary costs and hospitalizations. Remote monitoring allows for early intervention and adjustments to be made in care and services to help patients avoid costly and lengthy emergency department visits or hospitalizations. This service also uses digital technologies to collect medical and other forms of health data from individuals. Devices electronically transmit the data they capture and transmit it securely, often to EHRs, for assessment and follow-up when concerns are identified. Remote patient monitoring data is typically monitored by a care management team at a central location, who will either directly follow up with patients or who will engage the patient's providers if concerns are identified. Common types of data that can be captured often include vital signs, weight, blood pressure, blood sugar, blood oxygen levels, heart rate, or electrocardiograms, or electronic meetings like Zoom calls with the patient. Remote patient monitoring has long been used as an evidence-based delivery method for management and support of patients with heart failure, but use has broadened to support patients with a wide variety of conditions. Common uses are chronic disease management, behavioral health services, home-based dialysis, and managing mild COVID-19 cases. There is also expanding use of remote patient monitoring to better support long-term care needs for patients while allowing them to stay in their homes. The financial rewards offered through value-based care to keeping patients healthy allows more freedom of choice in how medicine is practiced. Some organizations have chosen to invest these rewards gained through their value-based payment contracts on this and other technologies, as the base of evidence is developing to support the acquisition and implementation costs are outweighed by keeping people healthier and out of the ER. Mobile health is using a mobile device to manage your health. Some common examples are the Apple Watch, wrist-worn fitness trackers such as Fitbits, and smartphones like Apple and Android, most commonly. There are hundreds of apps you can load onto your phone that will help with monitoring of chronic disease, prevention for addiction services, management of depression, and healthcare surveys. Mobile health enables us to collect data and incorporate it into an EHR, which can help paint a better longitudinal healthcare picture. This data can also supplement the information in population health management applications to help drive early interventions. One of the unique aspects of mobile health applications is that consumer demand for their health information is driving the use and development for this technology, not primarily from the healthcare sector itself. An analogy for this outside the healthcare industry is the demand and use of financial apps on our smartphones and computers, plus remote and instantaneous payment apps. Just as consumers demand and expect use of and access to their financial information, so too is the demand and expectation that patients be able to do the same with their healthcare data. Care coordination involves deliberately organizing patient care activities and sharing information among all participants concerned with the patient's care team to achieve safer and more effective care. Care coordinators also help the patient become more involved in their care by assisting them with navigating and understanding their options and choices within the healthcare system. Care coordination in rural areas has its unique challenges, and a shift towards value-based care can improve capacity to better support patient needs. A few examples. Public payers account for a large share of the overall mix in rural areas. Their relatively low reimbursement rates combined with a limited private insurance base often put a financial strain on rural providers. Pursuing collaboration and coordination with other organizations in their service areas can strengthen the financial position of rural providers by allowing them to participate in value-based payment models and creating opportunities to share resources. Health workforce shortages in rural areas can limit access, hitting primary care and mental health services hardest. Over half of primary care medical health professional shortage areas, HPSAs, are located in rural areas. Approximately 65% of rural counties do not have access to psychiatrists, and 47% do not have access to a psychologist. Collaboration and coordination among providers can lead to more effective and efficient service delivery implementation, which can assist in recruitment and retention of healthcare professionals. Collaboration and coordination can help maintain and enhance healthcare access through reducing duplication of services, thereby potentially ensuring longer-term viability of organizations and services in the community. Social determinants of health. By coordinating with other community-based organizations, you can appreciate and incorporate some of the non-medical factors into decision-making with your patients, which impact health and access to care, like health literacy, income, employment, housing quality and stability, the strength or weakness of social relationships, access to transportation, and availability of nutritious and affordable food. This helps reduce the problems that contribute to increased chronic conditions, substance abuse disorders, and shorter life expectancy in rural areas. Most of the tools we'll talk about next are aligned with opportunities to better support and address care coordination needs. Public health registries could include, but are not limited to, birth defect registries, chronic disease registries, and traumatic injury registries. Some registries have been developed by professional organizations, specialty organizations, patient advocacy, and quality improvement organizations. Registries in general enable data collection, knowledge to drive process improvement regarding the diagnosis, therapy, and prevention of conditions that affect a population. Merit-based incentive payment system, or MIPS registries, are entities that receive and report quality data to the Center for Medicare and Medicaid Services on behalf of eligible clinicians. Note that there frequently is a cost associated with selecting and using a certain registry to report data for MIPS. There are different reasons you might want to, need, or have to use registry services, such as an obligation to report to registries as part of a quality program, such as MIPS, which is part of CMS's quality payment program. You may be reporting data to a registry and want to see how you rank in comparison for your selected quality measures. You might wish to pull individual patient info, such as confirming immunization history, in that type of registry. Depending on the registry, you may have the ability to pull larger data sets and incorporate that data into your population health management analytics application to help derive greater insights from your data. EHR patient portals are an excellent tool for patient engagement, and the functionality contained in portals is enabling broader and deeper engagement over time. Overall, they are an enablement tool for patients to understand and engage in their health in a variety of ways. They provide information about preventive screenings that may be due, appointment reminders, lab results, visit summaries, and other opportunities listed here. We encourage you to consider how your organization can use a patient portal to help keep patients well in the proactive value-based care environment, and consider how your patient portal may be used to move the needle on quality metrics that measure patient engagement and satisfaction. We're going to shift gears a bit to focus on opportunities for ways that technology can be used to support information exchange, which can be a key strategy to support proactive patient care. Let's start by talking about what we mean by health information exchange. Electronic Health Information Exchange, HIE for short, allows doctors, nurses, pharmacists, and other healthcare providers to appropriately and securely access patients' vital medical information electronically, improving the speed, quality, safety, and cost of patient care. As technology and standards of data exchange evolve and improve, HIE will play a great role behind the scenes, also enabling patients to access and utilize their healthcare data and control who has access to it as well. Appropriate, timely sharing of vital patient information can better inform decision-making at the point of care, the right information at the right time for the right patient in the right format, and allow providers to, for example, avoid readmissions, avoid medication errors, improve diagnoses, decrease duplicate testing. Despite the widespread use of electronic health records in individual healthcare organizations or health systems, there are continued opportunities to better connect and share information across organizations or between providers. EHRs were and still largely are designed to handle the needs of individual facilities and locations where data is entered, used, and stored, but not shared between locations. However, this is changing, and HIE is the secret sauce that is making this happen. The importance of HIE to engage in value-based care can best be described by using an example from the travel industry. When you plan a trip and book your hotel stays, airline tickets, and perhaps a car rental, you rely on services and technology standards that can quickly pull the needed data together, display it in an organized way so that you can make the best informed and appropriate decisions for your travel needs. Healthcare is aspiring to these same abilities, pulling data from many locations, databases, organizations, and assembling a patient's full health history in a way that is quickly usable at the point of care. The ability for HIE to enable access to disparate and physically segmented patient data can greatly improve the completeness of patients' records, which can have a big effect on care, as medical history, current medications, and records in other systems at other physical locations can be accessed and reviewed at visits. Ultimately, the goal is to achieve a full 360-degree or holistic understanding of a patient's health history and health story, to the extent that it has been documented and stored in EHRs and other care applications, which can only be assembled when and where needed by using the capabilities provided through health information exchange. There are many types of information that can be exchanged beyond the few examples listed on the previous slide. For example, a primary care provider can directly send electronic care summaries, also known as continuity of care documents or CCDs, that include but are not limited to medications, problem lists, and lab results to a specialist when referring their patients. This information helps to inform the visit and prevents the duplication of tests, redundant collection of information from the patient, wasted visits, and medication errors. Emergency room physicians may also need to use data from a CCD, but focus more on medications, recent radiology images, and problem lists, then supplement that with immunization data from a state immunization registry. Having this information facilitated by HIE might inform them to adjust treatment plans to avoid adverse medication reactions or duplicative testing. HIE is an evolving field, and the means and methods to exchange are evolving, with new acronyms like FHIR or FHIR, Fast Healthcare Interoperability Resources. FHIR determines how the data is standardized or normalized so different systems are all speaking the same language. Think about how Apple and Windows PC environments differ and how they can't always speak the same language. There are also other behind-the-scenes standards that are becoming widely accepted, like APIs, Application Programming Interfaces for Healthcare, that are the handshakes from your EHR to the wider world of information using internet-based protocols and standards. In most cases, It is not the technology that is the barrier, it is the trust and confidence we need to have to be assured that the data is accurate and reliable and that it will be transmitted via health information exchange in a secure manner while observing privacy and patient consent considerations. There's a shared nationwide interoperability roadmap which provides a broad perspective of where we've been on the HIE journey and our goals for 2024 and beyond. The link for this PDF roadmap is available in the reference slides. The availability and accessibility of health information exchange varies from state to state. Most states have some form of state-level HIE or multiple exchanges within some larger states like New York and California. Some states have combined efforts to gain economies of scale, like Colorado and Arizona. HIE organizations have developed inter- and intra-state partnerships, and the technical aspects and standards to facilitate trust and exchange across the country are well underway and being expanded for new use cases, including social determinants of health data. While HIE is taking time to implement and adopt, the value of electronically exchanging is multifold, including having the data much quicker, integrated into the EHR alongside existing data created by the receiving facility, the standardization of data, and more. One of the challenges that health information exchange organizations have faced is their long-term financial viability and stability. There are challenges in deciding how to charge for their services, such as a single annual fee regardless of the amount of data exchanged, or on a usage or volume of services used basis. Some rural providers have experienced the barrier or hurdle when desiring to onboard with an HIE due to cost and the uncertainty of future costs, as well as other factors such as simply the connectivity available in their areas. Overall, what enables value-based care models is the ability to understand and draw insights from large sets of population data, and HIE is a method by which we can access and incorporate data into our population health management analytics processes. The field of health information exchange is a dynamic one, and generalizations can't be made that may apply to your specific locality or state. However, there are some excellent resources that can guide you through some considerations if you are new to HIE. Those are located at the healthit.gov website and the National Rural Health Resource Center HIE Toolkit. You can find both of these web page links in the resources page at the end of this session. The main point is that we are moving beyond the restrictions or siloing of data within EHRs to a liberated environment with the proper privacy, security, and consent considerations, and doing so in a methodical manner. There is much more to learn and know about HIE, such as the work and capabilities offered by national exchanges known as Care Quality, Commonwealth, the eHealth Exchange, each of which evolved out of specific needs or collaborations to serve as trusted entities to mobilize data. There is also oversight at the national government level to create structure and organization of the many HIEs throughout the country. Next, we'll talk about another model of data exchange which moves beyond thinking about just healthcare data and includes broader sets of data from behavioral healthcare and from community-based organizations. Community information exchange brings together data from healthcare provider, behavioral health, and community-based organizations to better coordinate care. CIE is the term that connotates bringing data together from these three domains to help assemble the holistic, longitudinal picture of an individual. This information is highly segmented or siloed throughout the country today, with a few exceptions. But with the proper privacy and security safeguards as well as consents, a better and fuller view of a person's needs can be established while concurrently seeking to reduce healthcare costs and improve the desired health outcomes, the two primary goals of value-based care. The larger goal is to assemble a longitudinal record that incorporates the three main sources listed at the top of the slide. We'll get into social determinants of health in the next few slides, data largely generated outside the walls of traditional healthcare. The technologies behind this enable communication between the three entities and also close the loop or provide the possibility of feedback when referring to other community or care settings such as schools, correction facilities, alternative care practices, as well as housing and food programs. As we know, stable housing and proper nourishment are primary indicators and predictors of good health. If you'd like to learn more about community information exchange, both San Diego, California and Grand Junction, Colorado have created CIEs within their communities and are frequently cited as models to emulate. Links to these CIE websites are provided in the reference slides at the end of this slide deck. In recent years, there has been increased attention and awareness of the impact of social determinants or social needs on health outcomes and healthcare costs. SDOH are the conditions that influence our health and well-being where we live, work, and play. Social determinants of health can influence health in positive and negative ways. Social factors, our physical environment, and health behaviors contribute to about 80% of our health and longevity, and it is estimated that clinical care, access, and quality contribute about 20%. Understanding key factors that influence health is important for people who work in rural communities because many of these factors can contribute to the less than optimal health that is often prevalent in rural Americans. Health disparities among rural residents are well documented, and the COVID-19 pandemic has exacerbated these already existing disparities, especially for people of color. As the shift in healthcare to value-based care and payment moves into its second decade, rural healthcare organizations are encouraged to embrace their role as community leaders and partners to better coordinate efforts and develop local strategies to address SDOH and improve health. Value-based care provides opportunities to shift resources to address SDOH challenges that obstruct optimal health and misuse healthcare resources. By collecting SDOH data at the individual patient and community member level, then aggregating it to local and state levels with appropriate safeguards, helps to inform policy decisions around program gaps and community needs. This recognition of the impact of social needs has led to a rapid increase in the use of screening tools to help identify patients' social needs. Community information exchange is a key opportunity at the intersection of clinical and social needs and can be used to target patient support and, when aggregated and analyzed, to better understand community-level needs and opportunities. As we've learned throughout the series, value-based care is highly dependent on data, and aggregating data about social needs at the population and individual level helps us to create the longitudinal care record and determine the appropriate targeted interventions. There are standards organizations such as HL7, which has convened and facilitates the Gravity Project, a group of about 1,800 participants over time from health and human service organizations who are seeking to bring standardization to SDOH data so that it can be combined and used alongside clinical data. When we've accomplished that, we can then combine SDOH, clinical, and behavioral data, which are the three components that are typically shared in a community information exchange. You can refer to the reference slides at the end of the slide deck to learn more about the Gravity Project. If you'd like to learn more about social determinants of health from a rural perspective, Rural Health Value published a 10-page guide on that topic entitled Understanding and Addressing Social Determinants of Health, Opportunities to Improve Health Outcomes, a guide for rural health care leaders. A link is provided for this in the references section at the end. Also, if you'd like to learn about 3 of the most common SDOH screening tools, you can refer to the final resource slide at the end of the slide deck. The data captured from SDOH questionnaires can be directly uploaded into many electronic healthcare records as structured data, and you may wish to check with your EHR vendor to know if this data can be captured, or if they are developing functionality for this if it doesn't currently exist. It is generally administered by clinical or non-clinical staff at the time of the visit, but a paper version can be given to the patient to self-administer and the data later entered into your EHR if it has that capability. Screening for social determinants of health is a task that can be accomplished by anyone with the proper training on the healthcare team. When completing SDOH screeners is performed by members of the healthcare team other than the physician, this frees up physicians to focus on patient care and work more efficiently, enabling them to work at the top of their license as it is referred to. Lastly, you may hear of some national level vendors that offer web-based applications to enable SDOH screening and referral, such as Unite Us, Aunt Bertha, NowPow, short for Knowledge and Power, and others. These vendors help build electronic catalogs of local, state, and nationally available community services and organizations and create a web-based Search and Connect workflow to enable need-based referrals along with feedback to know if the referral was followed up on. In this session, we cover details of how many different technologies enable care management and care coordination for individuals at risk and what the primary technology tools are that help to support value-based care processes. You may be working with a number of these technologies already. What may be new is how they can be combined and used to support value-based care workflows. In the fourth and final session that follows, we will cover 2 specific use cases and assemble the lessons learned from the first 3 sessions and see how people, processes, and technologies are combined in these value-based care scenarios. The content of this session is based on many articles and web-based resources, and those are available in the following slides, along with resources that have not been mentioned but you may find useful. A separate PDF document is available with the slides for this session, including the reference and resource slides that follow. The following slides that you'll see briefly have active hyperlinks in the PDF document to make the references and resources easier to access. Thank you for taking time to review this third of 4 sessions.